Okay, this week's lecture is going to be on staph, otherwise known as Staphylococci. When we look at staph, micrococcus, and other organisms that fall into this classification, as you've seen in Chapter 13, we have a list of organisms here. I'm going to go ahead and read them to you so you're familiar with how they're supposed to sound. The first one is Staphylococcus aureus, which includes MRSA, Staphylococcus intermedius, Staphylococcus epidermidis, Staphylococcus saprophyticus, Staphylococcus lugdunensis, coag-negative Staphylococci, and micrococcus. These include some other staph, which is capitis, hominis, auricularis, xylosis, and simulans, and more. The majority of what we are going to discuss will be found in the left-hand list. Here are some general characteristics. The Gram-stain reaction is gram-positive cocci. It looks like you see it here. It looks like clusters of grapes. They're catalase positive, and the primary pathogen would be Staphylococcus aureus, if you want to add that to your PowerPoint. Some of the things that we see in somebody with a Staph aureus infection, we see scalded skin syndrome sometimes. Toxic shock syndrome can be caused by Staph aureus. Certain types of food poisoning, which is usually caused by the toxin that comes from staph. Folliculitis, which is a skin infection. Furuncles and carbuncles, which are deeper skin infections. Impetigo, we can see wounds or abscesses. Bacteremia, endocarditis, osteomyelitis, cerebritis, pyelonephritis, which is a kidney infection, and many other infections. As you can see here, it affects many different areas of the body. With Staph aureus, we can see them in the nasal carriage. Some people are constant carriers. They find that healthcare workers, such as nurses and things, when they're working in a unit with immunocompromised patients in particular, they will actually test the nurses in their nasals with a nasal swab to see if they carry MRSA. If they do, they'll treat them before they're treating patients to make sure that they're not going to be passing that on to the patients. People can be intermittent carriers where it comes and goes, or non-carriers. Again, there's a higher rate amongst healthcare workers to be carrying those things persistently. And then in immunocompromised patients as well, we see them more often. Most of us have Staph aureus somewhere in our body and it doesn't affect us. It becomes a problem when it becomes MRSA. Other locations where we see it, the nasopharynx, the perineal area, the skin, and it can be a colonizer of the mucosa. There's different modes of transmission: endogenous, which would be more inside, direct contact, or indirect contact. So here's an activity that you can take some time to do. So using the handout provided, fill in the appropriate information regarding Staph aureus toxins, enzymes, and infections. Your textbook is going to be a great reference. You can see this in Chapter 13. These are printable within your online course. It says here you can work as partners, but if we're not in a classroom situation, you can certainly go and fill those out. So I recommend pausing this video at this time, using Chapter 13 to fill in that chart, so you can just become familiar with some of the toxins and enzymes that are associated with infections. Okay, so back to the Staph aureus. There's some different things that we see. Hopefully you just spend some time looking at the chart and filling some in. But staph has a lot of ways that it can infect people. It's got enzymes such as coagulase and staphylokinase, which are secreted. It's got toxins, toxic shock syndrome toxin 1, enterotoxin, and alpha hemolysin. It's got invasins such as pantonvalentine and leukocidin. And it also has some membrane-bound factors such as collagen-binding protein, fibronectin-binding protein, and elastin-binding protein. There's different areas of the membrane. As you can see here, there's a plasma membrane that binds penicillin. There's a peptidoglycan layer, and there's a capsule slime layer as well. Those slime layers make it difficult for other cells to phagocytize the bacteria. When we do staph testing, one of the types of tests we can do is a coagulase test. So for gram-positive cocci that are catalase positive, in which case Staph would be, we would next perform a coagulase test. Staph aureus is coagulase positive. All other Staphylococci are coagulase negative. There's two ways we can do this. There's a bound coagulase, which is clumping factor, or an extracellular free coagulase type of test. The one you see on the left here is a slide coagulase test. Okay, it uses a traditional slide type clumping. We mix a colony of the bacteria with the coagulase. If it clumps, it's Staph aureus. If it doesn't, then it's not. Tube coagulase, you can see it's positive here. It formed a clot, kind of like we did in coag. No clot meant it was negative. So those are two different types of coagulase tests we can do. We're going to be doing the slide test in lab. So the bound coagulase, which is actually clumping factor, is what we use in the rapid slide test that we'll be performing. It looks just like this. 10 to 15% of Staph aureus can actually give a false negative due to the capsule interference. We can also see false positives with Lugdunensis and Schleiferii. If you suspect that you have a Staph aureus but you get a negative slide test, a tube coagulase should be performed. So with the tube coagulase, what we do is we inoculate a tube containing plasma. We incubate at 35 degrees Celsius for 1 to 4 hours, and the production of coagulase enzyme results in a clot formation, as you can see in the top. It's important not to read them past the 4-hour mark, or you may end up with a false negative. We can also see false positive with Staph hemolyticus, hominis, and saprophyticus, which is why we use the slide test more often. When we look at Staph aureus on the blood agar, we see medium to large colonies. They're usually smooth, entire, slightly raised, low convex, and opaque. Most colonies are pigmented creamy yellow, as you can see here, and most of them are beta hemolytic. So as we hold the slides up to the ceiling, we'll be able to see through it. There's additional selective media that we can use. Polynethyl alcohol, which is P agar, inhibits gram-negatives. Columbia colistin nalidixic acid inhibits gram-negatives, that's CNA agar. We can see recovery from thioglycolate broth when there's not much specimen available. And mannitol salt agar, so this differentiates organisms that use mannitol. We'll use some of that as well. Another neat one that we use is chrome agar. This is available for the identification of MRSA. If there is MRSA, we do see denim blue type colonies, as you can see here on the plate. It's very pretty. They're kind of shiny too. So the biochemical testing that we do on Staph aureus includes a catalase. It'll be catalase positive, and it'll be novobiosin resistant positive. Everything else on here would be negative. There are molecular methods that can be done nowadays using PCR. There's a MALDI-TOF that is done, which is a matrix-assisted laser desorption ionization time-of-flight mass spectrometry. That's a mouthful, but they do have that at ThedaCare, and they're starting to bring more and more tests on board with that one. What it does is it allows us to identify if an organism is present within a couple hours rather than a couple of days. With the antimicrobial susceptibility with Staph aureus, we see that Staph has developed resistance to some antimicrobials. For example, the MEK-A gene encodes PBP2A, which is an altered penicillin binding protein. Staph aureus strains that have MEK-A are considered MRSA. Okay, so if you have that, that means you got methicillin resistant Staphylococcus aureus. MRSA can be oxacillin sensitive or resistant, so usually they'll do sensitivity testing to see. MRSA can be, cephatoxin disc diffusion can be used to detect methicillin resistance. We also have beta-lactamase production that can be tested using the nitrocephin disc test. All in all, vancomycin is usually the go-to drug for the treatment of these resistant strains. But now we're finding vancomycin resistant Staph aureus. We can see macrolide resistance, which may be expressed or inducible. Inducible expression will be activated in the presence of erythromycin. And to determine clindamycin sensitivity, you must perform a D-test on erythromycin-resistant strains. So here's an example of the D-test. We're going to take and put Staph aureus all over the slide, we're going to add an E disc and a C disc. If you see a zone of clearance with the, it looks like a D, as you can see on the right-hand side, it would be positive. Positive for a D test if it looks like a D. All right, let's look at some other Staphylococci. So Staphylococcus epidermidis is capable of a biofilm formation, which has an exopolysaccharide slime layer. It can also possess something called delta toxin. Most often, Staph epi is found as normal flora, especially on your epidermis, on your skin, but it can cause nosocomial infections, especially if somebody has an indwelling or prosthetic device. So if you have some type of a catheter or something like that, it can cause infections. Where it normally doesn't, it certainly could. And the blood agar, they're small to medium colonies. They're opaque, grayish white. They're mostly gamma hemolytic strains, and they can be very sticky. These are coagulase negative, novobiocin sensitive. Staphylococcus saprophyticus. This is one that can cause UTIs in sexually active young women, and infections outside of urinary tract are uncommon. On blood agar, we see large, entire, very glossy, smooth, opaque, biturous, convex, and usually white gamma hemolytic colonies. These are coagulase negative and novobiocin resistant. So that's how you would determine the difference. The next one is Staphylococcus intermedius. This one is resistant to lysozyme. It has an exfoliative toxin and can have enterotoxins. This one is usually a normal flora in dogs. When we see this, it's usually from the wounds from dog bites. On a blood agar, they're going to be large, slightly convex, smooth, glossy, translucent, usually non-pigmented, and maybe beta hemolytic, as you can see here. This one is coagulase variable, so it may or may not be positive. Staphylococcus lugdunensis. My last students would call this one lugs. He has virulence factors very similar to Staph epidermidis. It can be normal flora, but we can see it in endocarditis, bacteremia, wound infections, and UTIs. On blood agar, they cause medium to large, smooth, glossy, slightly domed center in the middle, unpigmented or cream yellow to orange color, and they can be beta hemolytic. The coagulase can give a false positive on the slide test for this one. So we could do a tube test. Some of the last ones we'll talk about are Micrococcus species, specifically Luteus and Lilae. They really don't have any virulence factors. They're usually considered a contaminant and rarely implicated in an infection. On a blood smear, they're usually small to medium, opaque, convex, gamma hemolytic. They're catalase positive, and one of the things we see are the tetrads under the microscope, which kind of leads us to believe it may in fact be a micrococcus. Tetrads mean sets of 4. Other types of coag-negative staph, some can be normal flora. On a blood agar, they're usually smooth, white-gray. They're coagulase negative, and they do not always need to be identified to the species level. So they may be actually called other coag-negative staph, and you could report that to the physician. He'd probably think, it's normal flora. So let's look at case study number 1. So case study number 1, we have a teenage male with a history of colitis, most likely Crohn's disease. He has had difficulty controlling his disease despite medication and management, including long-term parenteral nutrition and pain medication. He attends high school and is socially adjusted. Even though his illness has caused him to be small in stature, he lives with his mother who works for a veterinarian, right? He was admitted to the hospital for abdominal discomfort and erythema at the exit site and along with a tunnel of his central line. Blood cultures were collected, and both the blood cultures and his catheter tip cultures grew catalase positive, gram-positive cocci. The tube coagulase test was positive, but the slide and latex test for coagulase were negative. Couple questions. I encourage you now to pause the lecture right here and look through these questions. You can find the answers in the textbook and through what we've just done. See if you can answer these questions, jot them down, hit play, and I will cover the answers. Go ahead and do that now. Okay. So for case study 1, what further biochemical testing should be performed? PYR is one test that can be done. Beta-galactosidase and VP will differentiate among the tube coagulase positive Staphylococci. In this one, it's likely Staphylococcus epidermidis. This one is VP negative and PYR positive and is a pathogen in dogs. It was probably acquired from the mother while working in the veterinarian's office. Number 2, explain the discrepancy between the tube and slide coagulase tests. So with this one, Staph intermedius is coagulase variable, so there could be a discrepancy between the two of those. Number 3, susceptibility testing for the penicillinase-resistant penicillins is problematic for coagulase-negative Staphylococci because they can be heteroresistant and express resistance poorly in vitro. This characteristic makes testing in the laboratory difficult, leading to reports of false susceptibility. What is the only reported mechanism of resistance to these agents? For this one, the only known mechanism of resistance is mediated by the MEK-A gene in Staph. That produces that penicillin binding protein 2A, and it does not bind well to either penicillin or other penicillinase resistant penicillins. Because of the difficulties with this expression, this is number 4, of the MEK-A gene product in Staphylococci, studies have been done to determine which antimicrobial agent best induces the microorganism to produce that protein. Which antimicrobial agent was found to best predict the susceptibility or resistance to the penicillinase-resistant penicillins? The antimicrobial agent to best predict susceptibility is actually cefoxitin. All right, case study number 2. An 81-year-old female was admitted to the hospital for a total knee arthroplasty. After the surgical procedure, she had no post-operative complications and a successful recovery. 2 years later, while living independently at home, she began to experience chronic daily pain in the knee and joint. To control the pain, she would take acetaminophen every several hours as directed. She finally presented to her orthopedic surgeon after a 2-month history of pain. Physical examination of the knee and joint demonstrated moderate swelling and mild erythema of the artificial joint. She experienced increased pain with weight bearing and passive range of motion. A new x-ray revealed no acute fractures or deformities, but did reveal a small effusion, indicating the need for arthrocentesis. The joint fluid revealed no crystals, 110,000 white blood cells, which is really high, and 25,000 red blood cells, which is really high. Here are some laboratory results that you can review to see what you think may be increased. The reference ranges are there. Okay, so I'll leave that there for you. And here are your questions for case study number 3. Review the results in the table. Identify the abnormal results. What could be a possible diagnosis? What additional laboratory tests would you do? And what organism might be implicated? Again, I'm going to pause the video, try and go through these questions, see if you can figure them out, and then I will come back and let you know what the answers are. All right, so for number 1, did you review the results in the table in the previous slide? There was increased WBCs and neutrophils. The increased neutrophils lead us to believe that there is in fact a bacterial infection. We saw an increased sed rate and increased CRP, which means there's a lot of inflammation, which is likely from the infection. Number 2, what's a possible diagnosis? Possible diagnosis would be septic arthritis with probably some type of coag-negative staph. What additional laboratory tests would assist in the diagnosis? We could do blood cultures, as well as a culture and sensitivity of that joint fluid to determine if there may be an infection. Hopefully the bacteria would grow. They would do aerobic and anaerobic cultures to help determine that. What types of organisms could be in this case? Some type of coag-negative staph, or it could be Staph epi. All right, so here we are at the end of Module 2. Make sure you review Chapter 13, complete your quiz, and next week we'll be looking at Chapter 14.